Good afternoon, everybody, and a very warm welcome to today's webinar. I'm Nathan Irwin, WPA's Chief Executive, and it's my pleasure this morning to introduce two female health experts, Professor Dame Lesley Regan and Lauren Chiren. I will let each of the presenters introduce themselves, but I can assure you, having already listened to the presentations, that they're both equally thought-provoking and insightful. The presenters will talk about breaking taboos, and I hope in some small way we can help take this forward on today's call. It's evident that female health has not featured as prominently as it should have done in boardrooms and leadership agendas in organisations across the country. Reflecting on this and taking the menopause as an example, it seems to me that the menopause is likely to coincide with the age at which people are at or around the peak of their careers. And therefore, it makes no sense at all that businesses have spent relatively little time discussing these expected events that are going to impact people when they are at their most valuable to an organisation and what can be done to support them. The presenters have certainly helped open my eyes to this, and I hope that you find today's session equally as useful. In a moment, I will hand over to the presenters. If you do have questions for them, please can use the chat function within the webinar software. And then at the end of the second session, Donna Revis, WPA's Chief Finance Officer, will chair a question and answer session. Thank you very much for taking the time to attend today. I hope you found it useful. And on that note, I will hand over to our first presenter, Professor Dame Lesley Regan. Lesley, over to you.
So thank you very much indeed, Nathan, for inviting me today. Thank you to WPA for having the foresight to think how important it is to have health and well-being for women in the workplace. I really think it's very important, and I would like to just introduce myself as one of the first of the two speakers. I'm an obstetrician and gynaecologist by training. I work at St Mary's Hospital in Paddington, but I'm the immediate past president of the Royal College of Obstetricians and Gynaecologists. And it's about that I wanted to really talk to you this morning, because during my 3-year tenure as president at the RCOG, I worked very hard on this report, which was launched at the end of December 2019, just as I was stepping down, and we entitled it Better for Women. And it was a proposal to improve the health and well-being of girls and women across the country. And instead of going topic by topic, we decided to adopt a life course approach, because what happens to girls and women at every era of their life then impacts on the next. And we wanted to flag up how important it was to access accurate education and information, to think about prevention and empowerment, not just doing things to people, and also to flag up to our government and to our policymakers at the Department of Health how fragmentation was making access to services very difficult for women. And our primary aim was to propose that we should create an NHS-led women's health strategy. Why? Well, I just need to remind you, women represent 51% of the UK population, but of course, their behaviour and their attitudes to healthcare influence the rest of society. They represent 47% of the UK's workforce, and they undertake 58% of unpaid caring roles. So I really strongly believe that women's health hasn't received the attention it deserves. I'll go further. I think women have been disproportionately disadvantaged by historical commissioning cuts. And there are enormous variations in access to and quality of services across the UK. Remember, this report was written before COVID-19 struck, and this last 8 months has brought home to all of us how inequalities in social factors have really increased risks of being ill and wellness. So women are experiencing health inequalities and outcomes that we could be avoiding. So at the start of my tenure as president, these were some of the statistics that the Department of Health were asking me to look at and help them unravel. Why was it that 45% of all pregnancies were unplanned? Extraordinary figure in a country that pioneered contraception. Why is it that 1 in 7 women are experiencing fertility problems and finding it difficult to access? And as my co-presenter Lauren is going to talk to you about, 1 in 4 women in the workplace are going through or have gone through the menopause. 1/4 of our workforce, female workforce, and we need to do more to understand and help them. And again, in a country that pioneered cervical screening to prevent cervical cancer, less than 75% of women are receiving cervical screening. Now, I had the honour of working with two Secretaries of State for Health, Jeremy Hunt and then subsequently Matt Hancock, and to give them credit, they were both very receptive when I said we need to have a women's health strategy. But they always used to say to me, but we've already got one, Lesley. And I pointed out that all of the women's health strategy focused around maternity. And so one of the comments I made to them both in jest was, you know, women's health is far more than incubating babies and delivering them. Please don't get me wrong. My work as an obstetrician has given me joy for the 40 years I've been qualified. But women are so much more than being pregnant and delivering a baby. They've got a whole life course of support. And as I was proposing to them, it's not difficult to predict what they need. This is a map or a chart, if you like, from 0 at the bottom here, age in years, up to 65 plus, just showing the healthcare needs that we can predict women will want or need. And you'll see here that every woman needs information about contraception and menstrual health and cervical screening. Many of them want pregnancy care, but not all of them, and that's usually a very circumscribed part of their life. And then, of course, as Lauren's going to go on to talk about, most women now of my generation will reach the menopause because they're living so much longer. Indeed, I'm going to be the first generation of woman who lives longer as a menopausal woman than I was reproductive, thanks to the changes in health and society. But we spend £97 billion a year on treating diseases and only £8 billion on prevention. And I think we have to change that ratio, particularly for women's health, because as I've suggested before, women really are the guardian of society's health because they influence everybody else. So we need our healthcare providers to have the resources they need to provide really well-rounded care and to include in that women's emotional and psychological well-being, as well as preventing future health problems. So we've got to move away from the disease intervention service that I was trained to work in towards preventative health. So we proposed that the RCOG would set up a women's health task force to improve women's health by empowering women to speak up openly about their health and their concerns. Also to raise awareness, and as Nathan said in his introduction, to break some of these taboos around very common day-to-day health problems. And most importantly, to improve the access and the quality and experience of care for girls and women across their life course. And of course, I kept pointing out to the Secretary of State, both of them, that if we did this effectively and collaboratively, we would have enormous potential to have efficiency savings in healthcare. Because if you use preventative measures, you save a lot of money. So here I am, a picture, this was taken at BBC House on the 15th of November 2018 with Jackie Doyle-Price, who was then the Minister of Health with the Women's Health portfolio. And we launched the Women's Health Task Force, which I co-chaired with her for the last 2 years on Women's Hour. And I always think if you've got Jenny Murray and Jane Garvey backing you, it really must be bona fide. It certainly caught the attention of the press. And these were the initial priorities we set ourselves. How are we going to tackle that incredibly high unplanned pregnancy rate? What's the problem with our contraception and sexual health services that we've got such a high unplanned pregnancy rate? We've got to break the taboos about menstrual health and fertility issues and the menopause. So as I mentioned earlier, 45% of pregnancies and around 33%, that's 1 in 3 births, are unplanned or associated with feelings of uncertainty. And there's very, very clear medical evidence that shows that when your pregnancy is unplanned, it doesn't have as good outcome. You might be a bit overweight, you may not have stopped smoking or drinking, your general health may not be better, you probably haven't been taking folic acid supplements. We know that 78%, that's 4 out of 5 women, are going to require support with contraception and or preconception advice at any one time. That's a lot of women, and they don't seem to be getting this if all those pregnancies are unplanned. And I just want to remind you that this is an absolute fact. Contraception is the single most cost-effective intervention in healthcare ever. It's quite unique amongst the medical interventions and the breadth of its positive outcomes, because this means that girls and women can choose if, when, with whom, and how many times they embark on pregnancies. And we know that when they space their pregnancies, that they're going to have much, much better outcomes. But access to contraception at this moment in time in the UK is really, really patchy. And the most effective hormonal methods, or the long-acting reversible contraceptives, the LARCs, are incredibly safe, incredibly effective, and they should be very easy to access. And we know indeed that the COVID pandemic has made it even more difficult for women to access this, and that many GP practices are saying that they can't provide it. We have to change that. And then I want to talk about a little bit about menstrual health. 1 in 5 women experience unusually heavy periods. periods that really disable them. Heavy menstrual bleeding is a very common reason for gynae referrals, about 25 to 30% of all women attending gynae outpatients. Pelvic pain affects around 1 in 6 women, and if any woman on this webinar has had pelvic pain, she will be able to vouch for the fact that this is a disabling part of life, and yet it can be treated. 1.5 to 2 million women currently living with endometriosis, and sadly I have to tell you that the average length of time it gets for a woman to get a diagnosis of endometriosis is 7 years, multiple trips to their doctors and specialists. Around 1 in 3 women are going to develop fibroids in their lifetime, again very, very common. 1 in 5 women have polycystic ovaries, and all of these things we can really resolve and treat the symptoms effectively if we can talk about them openly and provide women with access to help. During the preparation of that Better for Women report, we did a big survey of women. We spoke to over 3,000 women across the country from all walks of life. And one of the factors that really came out was the stigma about periods, menstrual periods. And I just need to remind everybody here that most girls and women have 12 periods a year for 35 years of their life. So this is a really very common problem. This isn't something that we shouldn't be talked about or they should be embarrassed about. And this was a survey done by the Wear White Again campaign, emphasising how menstrual health disorders have a huge impact on women's and girls' physical and mental well-being, and also on their ability to carry out their jobs. This survey found that 74% of women experienced anxiety, 69% depression, and many of them became anemic. 72% said it affected their sex life, 58% unable to carry out their usual daily routine. For many of that meant days off work. 50% had never been to see a GP about their heavy periods because they'd just been told they had to get on with it. And nearly 2/3 didn't realise that heavy periods are a medical condition for which there are lots of simple treatments. So women report feeling unheard with regards to menstrual issues. And I know that WPA is an employer of many young women in their 20s and 30s. So I think it's so valuable that you're holding this webinar and raising this issue and raising awareness. 61% of the women we surveyed couldn't access fertility services locally. I don't have time to go into that in great detail, but happy to answer questions. 34% didn't attend their last cervical smear test, not because they didn't want to or couldn't be bothered, because they found it very difficult to get an appointment, it wasn't at a convenient time, etc., etc. 48% of all the women we surveyed thought that a one-stop shop or clinic for all routine women's health service would really improve their access, and I totally agree with them, and that's the proposal that we put to the Department of Health and to the Secretary of State, to centre care around women, not make women go around umpteen different doctors and nurses to get their smear and their mammogram and their period sorted out and their contraception or their HRT, but actually for women to be able to access one place, go along to an appointment, only have half a day or an hour off work and get on with this, rather than multiple visits to multiple different places. So at the RCOG satellite meeting, one of our suggestions was better education on menstrual well-being, better information on the NHS website. And when I say the website, of course, I'm of the generation where I tend to read things and I tend to read hard copy paper. But of course, my daughter's generation does everything on their mobile phones and digitally. So we've got to be savvy about the way we impart this information. But most importantly, we wanted to focus on having women's health centres where women and girls can access all of their healthcare needs in one location swiftly. Because remember, most of the things that I'm talking about and that Lauren's going to talk about are not illnesses so much as maintenance. They just want to remain healthy and functional people in life. And to have a wellbeing at work charter to help break down taboos of women's health issues that can affect them at work or prevent them from working, and above all, listening to what they want. So I was very proud of the Better for Women report. We toyed with the idea of calling it Better for Women, Better for Less Money, but we thought we shouldn't just focus on the finance. But undoubtedly, if we were to implement all of the recommendations in this report, we would undoubtedly improve the health and well-being of girls and women for the better. So I'd like to propose that we do keep on pursuing a women's health strategy, because when you get it better for women, you get it better for everybody. And here is just a pictorial representation of all those life stages which we want to be able to enjoy to our potential. And I'm going to leave you with a little bit of a plug for the Wellbeing of Women charity, for which I recently became the chair. We have an ongoing Christmas fair that's still going till the 7th of December. So log on to Wellbeing of Women on the web and you'll be able to go shopping and donate to Wellbeing of Women. And lastly, on Sunday morning, I'd like you to tune into the BBC4 radio charity appeal when Jennifer Saunders, who's one of our supporters at Wellbeing of Women, is going to be talking about why she wants you to support and donate to Wellbeing of Women. I rather love this quote from Jennifer's at the bottom on the left-hand side of this slide. I don't think you can have a healthy society unless you have healthy women. So thank you, Jennifer, for that. And thank you, Nathan, for inviting me. And I'm now going to pass over to Lauren, who's going to, I think, focus more on the menopause. Lauren, we're really looking forward to hearing what you're going to say.
Thank you so much. And it's such a pleasure to have the opportunity to chat with you here today and share a little bit more than Leslie's had an opportunity to talk to in regards to menopause. So perhaps it would be useful if I just give you a little bit of an insight as to why I want to talk to you about menopause and why that's super important to me. So let me take you back 6 years to the 5th of November 2014. I was really excited to get invited to go and have a meeting with my boss, and that might seem a bit odd, but it was my birthday and we didn't normally get together. We would normally just catch up in between meetings on the way in or out of the office, and it was a really seamless, smooth relationship. So I thought there was a surprise in store for me. And there was. We had a very tricky conversation, and it went along the lines of, well, let me just cut to the chase. It was, you're walking around this place as if you've got the weight of the world on your shoulders. Not quite the look of a senior leader. Perhaps that's something you need to think about. I was absolutely shocked because the previous week I'd received an award and my bonus and everything felt like it'd been going really well. But I did go home and I did reflect. And when I thought about it, I realised that I hadn't been sleeping well for about 18 months. I'd struggled to speak up in meetings and I worked in transformation, so planning was a big part of my job. I sat in a board meeting and I couldn't get the word plan out of my mouth. I must have used 15 sentences to try and describe what I was trying to say. I became increasingly dependent on my team to make sure that I was in the right place at the right time, making sure that I was pushing things forwards in the way that I always did. That meeting with my boss really knocked my self-confidence and my self-esteem, and it really made me question whether or not I had early onset dementia. So I left my job rather than asking for help and being seen as weak as a female leader in a very male-dominated work environment. So you can imagine my surprise when I went to see my doctor and he turned around and told me I'd just been through an early menopause. You see, I was in my early 40s and it hadn't crossed my mind that any of this stuff was related to a natural, normal life cycle. I retrained and I've spent the last nearly 7 years supporting organisations how to become menopause savvy, to protect their female talent and make sure that as women are getting to this age and stage of life, that they can retain their skills, knowledge and experience and continue to thrive in the workplace. I've worked with companies all across the world, from Russia to the States and back again. And it's been a real privilege to watch those companies flourish and start to see their female talent go on through the organisation. As I said, I've retrained, and it's quite interesting because my experience, I went to university to do double maths and computing and came out with a psychology degree, and that tends to be a little bit of the story of my life. I start off in one direction and end up going somewhere else. But what it's meant is over the years that I've gathered lots and lots of qualifications, experience and knowledge about how the mind-body-brain connection works, how we choose and make our lifestyle choices and what our mindset is like and how that impacts on our performance. So my mission now is to really genuinely change global attitudes towards menopause, because it's going to benefit every single one of us, as I'm going to demonstrate. So today I'm just going to give you a quick canter through why we need to be talking about menopause. I'm going to go through the demographics. We'll have a look at some of the quick facts that you probably already know, but I'll just share a few with you because there might be a few surprises in there. I'll go through the business case about why as an employer it's so fundamental to be menopause savvy. And I will share how, although menopause doesn't have specific regulations or legislation that covers women going through menopause, how actually there is some cover out there. And we can talk about what you can do now at the end of this call to go away and start thinking about how you can become a more 'inclusive employer. So, demographics. I love this quote by Peter Drucker. The best way to predict the future is to create it. If you're an employer who's committed to a certain percentage of women on your senior leadership team, if you've decided that you've got a certain demographic that you want to create in your workforce, then you actually have to plan and put in place the things and the environment and the culture that enables you to do that. Women over 50 are the fastest growing economically active group in the UK. And as Lesley said, 1 in 4 women in the UK who are working are going through menopause. That equates to between 5 to 6.5 million women in the UK alone. And the stats elsewhere, obviously, are very, very similar. How many companies have committed to having 30% females on their boards? And yet, when you look at what's actually going on, the culture has not been created to either keep those women when they join, or there is no depth and strength in the succession planning for women to come through the organisation. So you may attract women at the very senior roles, but then there's a gap between your typically 60 to 70% women in entry level to mid-manager roles, and then a gap when it comes into senior leadership. We tend to lose women aged 35, give or take a few years, because of having families, and then we tend to lose women again between 45 upwards, again because of menopause. During COVID, stress and anxiety levels have gone through the roof for so many people. There are surveys coming out every single day just demonstrating how the impact of COVID, the uncertainty, and everything else that's going on has had a very, very negative impact for a lot of people. And that, again, has impacted women going through menopause as well. So my question for you really is, how are you building strength and depth and resilience within your organisation? So just to put menopause into context, if we just go through a few of the kind of key aspects of the menopausal journey so that this makes more sense. Typically, a woman going through her monthly cycle, she goes from her adolescent years, goes through whatever her normal cycle is for her. And that's called pre-menopause. It's before we enter any of the menopausal journey whatsoever. When the monthly cycle starts becoming a little bit more erratic, potentially, it might find cycles become longer, shorter, heavier, lighter. Everyone's journey is different. That's called perimenopause, and that's a time when women might start to experience things like brain fog, anxiety levels creeping up, headaches on a monthly basis, sleep disturbances, night sweats, brain fog, all these type of things. Once one's gone 12 months without a monthly cycle, they're deemed to be menopausal. So that 12 months after the last bleed is when they are actually menopausal. It's like an anniversary, a moment in time, and thereafter they're post-menopausal. So just to give you context, I'll use the word menopausal, meaning everything from the beginning of perimenopause all the way through to post-menopause. It's a lot easier than saying the whole thing all the time. Typically, the whole journey can take between 3 and 15 years, depending on a whole variety of factors, whether it's genetics, lifestyle choices, all sorts of things, but no 2 women experience menopause the same. If I was to do a survey just now and ask you how many symptoms there were, I just invite you to think about that for a moment. There are physiological symptoms, emotional symptoms, psychological symptoms. There's around about 30 to 40 symptoms. People often say there's 34 recognised symptoms of menopause. I've mentioned a few of them, but other ones are things like joint pain, hair loss, bladder problems, incontinence, stomach problems, gut problems, itchy skin, all sorts of different things that can really impact a woman going to work, really impact a woman's day-to-day life if she doesn't have the right help and support. And the great thing is that with the right help and support, a woman can completely thrive through menopause. And whether that's through natural lifestyle choices, complementary, alternative therapies, whether it's through HRT, there are many, many options out there. However, as Lesley has been saying, we don't have the right access to the right support. Currently, our GPs don't receive the training systematically within their medical preparation for becoming a GP on menopause. So unless someone's a specialist or they've taken an interest, they may not have that experience. And as we know, menopause is not a topic that many employers are currently talking about en masse. This time last year, we did a survey and showed about 5% of employers had menopause policies, and we had 13% when we repeated the survey this year. So things are moving in the right direction, but there's still a way to go. The age range is not necessarily what you might think either. So my menopause probably happened when I was about 37, when I had my son, and I think I probably became menopausal straight away. Now, the reason I didn't know what was going on was because I was on the contraceptive pill that meant I didn't have a monthly cycle. So I had no clue what was really going on. So for me, it was very early compared to the average. The average age of someone becoming menopausal, i.e. post-peri, but menopausal, is between 45 to 55, age 51 being the sweet spot when the average person becomes menopausal, but it can easily be earlier and it can easily be later than that as well. Now, interestingly, keep that age of 51 in mind and that age range of 45 to 55 in mind. In between the ages of 45 and 55, there's a spike in divorce. There's a spike in women leaving their jobs feeling unsupported or entering performance management for the first time in their lives. And there's also, at the age of 51, there's a spike in women attempting to take their own lives as well. There's plenty of research going on right now to look at the correlation between those numbers. However, I don't believe after 7 years of working in this space that it takes a rocket scientist to know that women's hormones are underlying a lot of these issues because we don't have the right access to support either medically, outside of work, or inside work. So I think it's really important just to be aware of the stats and be aware of, just the massive impact. The BMA themselves did a survey of their own doctors recently, and they showed that 93% of women were having symptoms of menopause. 67% were experiencing physical and mental symptoms, and they were leaving the organisations, leaving the NHS in droves. Because women at senior leadership role, women in many roles do not want to be seen to be weak. They don't want to be asking for help and support. And we are losing women from the workplace hand over fist because we just don't understand, don't talk, and bust this topic of menopause. It still remains taboo. So I'm hoping that today you'll be able to say the word menopause out loud once a day at least until it just becomes a normal word for you. Recently, I worked with women in women in hospitality, tourism and leisure, and we produced a white paper on menopause at work. I do believe there'll be a link sent out with the replay of this for you to have a download of that and have a read in more depth of the information of the impacts of menopause at work. The business case kind of speaks for itself, and I'm going to invite you to committing to running your statistics. One of my clients who I started working with about 5 years ago is a global trading bank. When we first chatted, it was simply because they saw me working with another bank and they wondered what I was doing. And they felt that as they didn't have a lot of women in the kind of age range of menopause, that it wasn't that big of a deal for them. So I invited them to go and run the statistics of how many women did they employ age 40 to 55, which is the kind of peri to post-menopause stage. How many people did they have in their organisation, potentially age 40 to 60, that may be living with someone who's going through a peri to menopause? How many grads do they have that are potentially still at home? And we looked at this in the round and they came back and showed that 81% of their staff were directly or indirectly impacted by menopause. Menopause is everyone's issue. If you're not going through it, you're being affected by someone who does at some point in your life. So no matter which way we look at this, it's really important to understand your stats and understand how much of your organisation is impacted by menopause, and especially if you want that strength and depth of your senior leaders. So I invite you to be really super aware of how you prepare, how you create job specs, how you advertise for jobs, what your onboarding process is, how you do your mandatory training throughout the year, how you weave menopause through your comms, your policies, your guidance documents and into your culture. Be aware of how you record absences as well. If someone's off, do you know that they're off with menopausal symptom? Or they just put it down to a headache or stomach ache or something else altogether? Are women aged 45 to 55 being misdiagnosed as suffering with stress and anxiety when actually it's menopause and possibly very easily treatable? So get closer to your stats and understand how it's impacting your organisation. If you've got someone who has been hugely beneficial, hugely useful in the organisation, filled with skills, knowledge and experience, and all of a sudden they go off sick and you can't backfill that role, their colleagues have to step in and take over the management of their teams, and ultimately they negotiate an exit, and you then have to replace them. The cost of that is likely to be somewhere between 150 to 212% of their salary. Never mind the lost skills, knowledge and experience, and never mind the impact that it's had to internal stakeholders and potentially customers as well. So I personally believe the business case, and I know my clients absolutely know that the business case stands up for itself. Menopause doesn't, and I won't go into this in too much detail, menopause doesn't directly have legislation covering it, but both in the Equality Act 2010 and Health and Safety Act have parts of them which will basically oblige employers to ensure that they are protecting their colleagues, their employees, and make sure that the working environment is fit for purpose. And it's something that I go into in quite a lot of detail when I'm working with my clients. But I invite you just to look at your policies, your procedures, your training, that entire employee journey to see whether or not you are menopause savvy and see what areas potentially you could improve in. So what can you do now? Survey your senior stakeholders and understand if they understand the impact of menopause. Understand whether they have even thought about this before, and perhaps take some core facts from today's session back to them. Look at your entire employee journey and where menopause can be given consideration. Review your policies and guidance. Understand how menopause needs to be blended into your communications, your networks, whatever, however you're communicating and keeping in touch with people, specifically while we're going through this blended way of working. And make sure you're signposting to places of help and support for your female staff so that they know how to get help and support for themselves. That's their responsibility. And as an employer, your responsibility is obviously to make sure that that access is there for them. Perhaps engage with someone who's an expert in menopause at work to come in and work with you. And certainly just have a think about what you might do next. What might you do as a result of listening to this whole session today? What action will you take? So I'm Lauren Chiren, and if you'd like to connect, LinkedIn's the best place to find me. And right now I'll hand back to Donna.
Thank you, Lauren. We'll move on to our question and answer session now. A number of questions coming in. First one is to do with hormone replacement therapy. There appears to be a lot of confusion and misinformation around. Can either of you provide a bit of clarity on this? Perhaps, Lauren, we could start with you.
Certainly. I think Lesley might have more detail on this simply because it's more of a medical space, but there's been a lot of misinformation as a result of a study that was done around about 18 years ago. And this generation, the last generation, unfortunately have had the concept that HRT is linked to breast cancer or DVT. GPs haven't been educated on HRT and menopause in the way that they need to, but perhaps, Lesley, you can provide a little bit more information on that.
Yeah, happy to. Thank you, Lauren, and thank you, Donna. I'm a great supporter of HRT because I really see how women really re-blossom when they're given HRT, and I look at it in the same way that it's replacing what you haven't got anymore, in the same way as if you had a problem with your thyroid, you wouldn't hesitate to take thyroxine because you need to replace what's going on in that gland. Lauren's right that in 2002 and 2003 there were two very important research studies published which have since been shown to be scientifically flawed. And what they emphasized was that women were getting higher rates of breast cancer in them, and that has always been a scary thing for women. And I think what's also understood now is that the studies that used populations of women who are far older than 50 to 60-year-olds that Lauren and I have been talking about, who are needing help in the workplace. So I'm going to go one step further. I'm going to say that when the MHRA, the Medical Healthcare Devices Regulatory Agency, last year put out another warning to GPs about risks of breast cancer, I got really, really irate because hormone replacement therapy, including estrogen and progesterone, does slightly increase the risk of breast cancer. But what's important for every woman faced with those options to consider is that no more women die of this problem, and they're much more likely to die of heart disease, strokes, or the problems of frail bones if they've been without HRT for long periods of time, or if they've had an early menopause. So I think this is another example of we need to give women the data to choose what's right for them. And I say this as a woman who's had breast cancer, not once, but twice, and still has chosen, when I look at my lifetime risks of what I'm likely to die of, I've chosen to remain on HRT because I know that I'm able to function better at work and for my patients. So that's been my choice. Other women would have chosen something different. So my plea, when you're talking to your GP or your gynecological specialist or your endocrinologist, is that you ask them to share with you the data so that you can make the best decision for you, not just get scared by the top headlines of the Daily Mail, which always go for the crisis management bit, and aren't really giving you a true viewpoint.
Thank you. And talking of crisis management, we've had a question. Do you have to go to a GP for diagnosis? And are there things that, are there many symptoms and services that are available for women to get assessed on a preventative basis? I mean, preventative, but you know, an early basis, so they know what's coming.
I think that's a really great question. And if you think about it, when we have children, they become adolescents, they go through puberty, we don't go rushing off to the doctors because their bodies are changing and their hormones are, altering throughout their body. Their behavior is perhaps slightly out there for a while. Boundaries go out the window. They might be very emotional. We don't go running off to our medics to help for support then. It's just that we don't expect women, when we get to midlife, to go through these things. We expect different behavior. We've become accustomed to them, handling whatever they're dealing with in a different way. So one of the important things for me, for menopause being raised, is that women understand what it is. Every study I've done, every piece of research I've read shows that women don't know what to expect. They get really surprised about what it's all about. And most people don't know that it can last for between 3 and 15 years, or that there's over 30 symptoms, or what the different stages are, or what the words for the stages are. So if we were better informed about what menopause is, we would know that we have to look after our health. We would know that we have to hydrate well, that we have to eat good quality foods, that the closer we get to middle age and menopause, we need to making sure we're getting good quality proteins into our diet. Now, whether you're vegan, vegetarian, or carnivorous, that's important. We would know that we need to move our bodies. Our bodies were made to move, not to be sedentary. We would know that it's important to have good, strong social bonds and surround ourselves with positive people. We would know that, having an attitude of gratitude was really powerful for your mindset. You can't be angry and upset when you're being grateful. So when you know how to look after yourself better, and you understand what peri and menopause are, then you can recognize the signs and symptoms, and you will know whether you need to be doing something to help you manage your stress and anxiety, whether you need to be looking at supplements or changing your diet, when's the right time to go to your doctor. But it's not something, unless your actual day-to-day quality of life is being impacted, there isn't that requirement necessarily to go to get medical advice. But as Lesley said, because of the preventative benefits of estrogen in your body to protect your heart health, to protect your bone health, then that is a whole other conversation. But in terms of diagnosis, it's a normal life stage that you're going to go through. Now, I don't know, Lesley may have a slightly different take on that. I come at it from, the health point of view, in terms of the health coaching mindset, lifestyle point of view. But medically, Lesley, is there something else you'd like to add?
Well, just going back to something I said in my presentation earlier, and that is that I'm the first generation of menopausal woman who's going to live longer post-reproductive or menopausally than I was reproductive. And although I'm not planning to live forever, I want to live as well as I can for probably what will be 30, 35 years, till 85, possibly 90. And what I know is that most women, after they reach the menopause, fall off the cliff in so much as they're not seen in the health service that we currently run, because we run a disease intervention service. We're not thinking about prevention, and we're not talking about explaining to them or giving them the information to factor in all those lifestyle issues that Lauren's just talked about. You know, weight-bearing exercise is crucial from stopping people becoming frail. I believe that thinning bones is inevitable. I'm quite slim. I've got quite a low BMI. I'm at much greater risk going forward if I don't have estrogen replacement, of having a fracture and then becoming immobilized and then becoming frail and losing my confidence. And it's a spiral downwards. Every physician who looks after or works in care of the elderly will tell you that once somebody falls over or whatever, breaks a limb or breaks something, that the spiral is just downward from there on. So I want to keep on my feet for as long as possible, doing as much as I can, both in the workplace and at home with my family. And I think that the evidence is absolutely clear now that HRT and other postmenopausal alternative therapies improve women's health and longevity and their potential for enjoying life greatly. And I think it's really important that no one's put off by scaremongering stories that are not evidence-based.
Moving on to the legal side of things, we've had a question. Obviously, Lauren, you talked about a couple of acts that that you were referring to, 2010 and 1974 acts. Should there be a change in the law to compel employers to be more understanding?
That's a great question as well. It's interesting, isn't it? Because what gets measured gets done. So from an employer perspective, I guess if there was legislation there, then, you know, at least we would have that to fall back on. Interestingly, there have been 4 successful employment tribunals that have cited, successful by the employee, that have cited menopause under either, well, actually all of them under the Equality Act. So again, under the protected characteristics of sex, disability and age. So we do have that cover. And whilst a woman going through menopause is not classed as being disabled, her symptoms, if they're lasting for over 12 months or round about 12 months or more, then she has the coverage under disability to have reasonable adjustments for her at work. So it's really, I would love to say no, I would love to say that is not necessary. However, if you look at what we went through to get some cover for maternity, then I guess once we start having regulations or we have legislation, that's when things actually happen, because they're getting measured, people have a voice, and people, you know, employers start to understand that they really do have to do something in this space. So my heart would love to say no, not necessary, but I guess, you know, my brain says absolutely. Let's just get this legislation through, get the protection and cover, and make sure that we can level out the playing field for women throughout their working lives.
And I think there's another point to make here as well. I mean, WPA, by running this webinar, I think is demonstrating the way we'd really like to see things go. That a big organisation that employs a lot of women recognises that they can get the best out of their workforce when they look after them, and that they're sensitive and show flexibility. So that's a great way forward. I mean, it's always a pity, isn't it? You think, you know, the great hand of the law has to come down to make something happen, but it is true. You can't monitor things that you can't measure. So possibly we do need some legislation. I'd like to think, though, that we'll be able to persuade more and more companies and big employers, particularly the NHS. You know, the NHS is the biggest employer of people in Europe, and 71% of the NHS workforce are women. I keep saying to the Department of Health, we should be making the NHS the very best place in the world for women to work. Wouldn't that be a shining beacon or an example of how you can get it right and improve, improve productivity? But I think, you know, pat on the back for WPA here, because what they're demonstrating here is that they've listened and they are considering all the people that they're employing. And I hope that many other employers will just see the common sense of wanting to make the women of whatever age they are in their workplaces have the best productivity and the best quality of life. Everybody will benefit.
Indeed, thank you. Sort of related question. What kind of policy changes should we be considering? I think you mentioned a menopause policy. What sort of features would that include?
So typically,
menopause policy so much. I think what we need to understand is that if we have women's health hubs, we will be able to get so much more done. So not every GP and not every gynaecologist will know a lot about the menopause. But if we have women's health hubs where where gynecologists, i.e. secondary care and tertiary care specialists can work alongside healthcare nurses, GPs, women will be able to go. I'm sure, Donna, you'd much rather go spend half a day or even a couple of hours going to have a whole variety of tests, your smear sorted out, your HRT or your contraception, or even your antenatal check with your mammogram, all those things all together. And this is not difficult to organise. These services aren't even that expensive to deliver. They just need to be organised around the woman rather than making the woman run around all the various hospitals and clinics. This is not rocket science. This is very, very simple to sort. But we just need some legislation to allow us to regroup and put the services where they're needed. And we also need to stop the very fractured commissioning, which has actually led to this situation of us becoming a little bit of a developing country or a third world country. It's rather extraordinary because women are not being able to access routine maintenance services. One of the things I always say is that when you take your car to the garage for its annual MOT, you don't expect to be told, oh, you can have the front tyres done here, but you've got to go to Brixton to have the back ones done. And we don't do oil changes. And windscreen wipers, no, you'll have to go to Birmingham for that. You know, we expect to be able to take our car in, get it serviced and take it away again. And I'm not comparing women to cars. I'm just saying that this is a maintenance thing. They're not ill. They're just wanting to maintain their health, usually because they're the carers, they're influencing the rest of their family. They need to be on tip-top form to carry on with their lives. And all we've got to do is to provide these quite basic, simple services in an environment that is useful and easily accessible to them. And we could do it very, very easily if we got rid of all the bureaucracy.
Sorry, Lauren, were you wanting to add anything there?
I think from the employer's point of view, it is about looking at the entire life cycle. It's not just isolating pregnancy or fertility or menopause. It's about acknowledging that the workplace was predominantly male until the Second World War, when women entered the workforce en masse. And you know, that's when we started to be in the workplace, but not necessarily have much of a voice in the workplace. And in recent years, as we've taken on more senior roles and senior leadership positions and starting to have more of a voice, then it becomes really obvious that we've kind of shoehorned ourselves into a very masculine environment, whereby we're the ones that have had to adapt and change and not bring our whole selves to work. And that's not healthy. That's not healthy for your psychology. It's not healthy in any way, shape, or form, kind of putting on a mask every day. You have to work so much harder. And that's where we need to get employers to look at their entire suite of HR policies and procedures. And we need to recognize that women are hormonal beings. I'm not, you know, we're all hormonal beings, but women have this monthly cycle. We have fertility challenges. We have other issues that go on. We may or may not have children. We will hit menopause if we live that long. And when you take that into consideration and you create a culture and an environment that embraces that, you can start to recognize, and women will start to recognize, when they're more creative, or they're more reflective, or they're more analytical as they change throughout the month and throughout their lives with different ages and stages. So for me, it's about a complete overhaul, and that's a big ask. So I am trying to influence and change the bit that I can, and that's in the menopause space. But more and more of my clients now are actually looking at the entire life cycle and looking at how they can change HR systems so that they can accommodate the changes and fluctuations of female hormones, because that just gets so much more productivity and helps, you know, that if you know your employer is going to do that, then your ability to step up and perform at your absolute best is second to none.
Yeah, that perhaps links actually to another of the questions, which you were talking about menopause, but one of the other things that's come up is miscarriage. Are there things that companies can do better to support women who suffer from a miscarriage?
Well, I think there are, miscarriage is another one of the big taboos, and it's a particular interest of mine, because in the 1980s, when I was a trainee in Cambridge, I was completely overwhelmed by the number of women who I'd seemed to be looking after in the middle of the night at the weekend on call, who'd miscarried, and I didn't know what to do to help them. And there was just nothing in the textbooks about this. And that's one of the reasons that I became so interested in research into why women repeatedly miscarry. But there are lots and lots of women who still find it extremely difficult to talk about miscarriage for all sorts of complex reasons. It's the commonest complication of pregnancy. And just like I was saying in my presentation, you know, we need to talk about periods because they happen, they're normal, they happen to lots of people. Miscarriage is incredibly common for reasons that I've never been able to fully work out. Human beings are really wasteful in the way they make embryos. We lose an awful lot of them due to genetic abnormalities in them. But most women I know, and I've now run a specialist miscarriage service for over 30 years, most women I meet in that service can cope with bad news about what happened. What they find very difficult is either not being able to talk about it because no one amongst their family or friends will acknowledge anything so personal or embarrassing, or having no information about it. So I think that they really do girls and women want to be investigated to see whether there are causes that they can understand. And I think, you know, the recent thing with Meghan Markle announcing yesterday how traumatized she was by her miscarriage, I think every woman on this webinar who's had a miscarriage will empathize with that. It really is very distressing. And much of the distress, I think, is endorsed by this feeling of not being able to talk about it. So I'd like to think that miscarriage is no longer such a taboo subject, but still for many women, they feel very unable to talk about it. And also, of course, it has big implications in the workplace, because if you talk to your boss about miscarrying, you've immediately identified yourself as a woman who's trying to become pregnant. And that, of course, has all sorts of other implications. So I think in the workplace, it's a particularly important one. So I think there's an enormous amount that you can do as employers to welcome women's, not confessions, but ask them to confide in their workplace managers and employers about what's happening in a way that they feel that they won't be judged or penalised or compromised going forward.
I 100% agree with that, Lesley, and I think that that's why it's so important to understand the full life cycle of a female. And
Yeah.
if we are training and educating our colleagues on that, and we're helping line management to recognise the signs and symptoms of people under stress and duress, then they can open a sensitive conversation or signpost someone to the right place for help and support. Employees don't always want to speak to their line manager about sensitive things. So it is, again, about just making sure that people are aware of all the different things. I mean, I've had horrendous situations in work where I've had a colleague, you know, off a couple of times for half a day unexpectedly, and pop up in the afternoon only to tell me they'd miscarried during the night, and they were coming in and carrying on with no support around them whatsoever. And I just find that absolutely horrendous. That just shouldn't be the case. And it is so important that we train our staff, that we understand the differences and understand that we make it safe for people to have these confidential conversations, and we can signpost help and support within or external from the organisation. But it's really important that we embrace all the different things that we can go through. And we are talking about women's health today, but it goes a lot broader than that as well.
And I'd add one more thing to that. As an obstetrician, I can be absolutely confident when I say that the one certain thing about pregnancy is that it always comes to an end within 9 months. So for every employer who's on this webinar, remember that if you make it easy for the women in your workforce to talk about their miscarriage or their ectopic pregnancy or their pregnancy, you're much more likely to have them want to come back to work swiftly and make a contribution to your workforce. Because pregnancy always ends, whatever the outcome, it ends. It's a relatively short space of time in a lifetime career at work. So you've got every opportunity to make women want to come back to your workplace if you welcome them undergoing these normal lifestyle events. This is a normal lifestyle event.
I've got a specific question about the contraceptive pill and whether it suppresses the natural system and therefore could be a cause of menopause.
Absolutely not, no. So the contraceptive pill is a combination of hormones. It depends which type you're taking. The modern day contraceptive pills are incredibly good at suppressing ovulation and preventing pregnancies. They really are very effective. But I'm a great supporter of the LARCs, the long-acting reversible contraceptives, the implants and the coils, because they are so fantastically efficient. They don't affect fertility at all. The moment that you want to become pregnant, you go and have them removed. They've very little systemic absorption. They're just, very few side effects. But of course, if you don't have to remember to take a pill every day or use a barrier method of contraception, it's not surprising that that's a lot more effective. So I would say get your LARC fitted, and then as soon as you want to embark on a pregnancy, have it removed, because it's not going to affect your fertility or your ability to have children. They really are a 21st century wonder, LARCs.
Just to add to that, interestingly, one of the questions I get asked quite a lot is that if you're on contraception, how do you know if you're menopausal? If you're on contraception, it means you're not having a monthly bleed. You won't. You would actually have to come off if that's what you wanted to discover.
Yeah, good point. Okay, I think we are pretty much out of time, so thank you very much for that. I'd like to thank our speakers, Lesley and Lauren, for such informative presentations and answering all the questions.